In this lecture, we're going to talk about pediatric asthma and how we should approach a wheezing child. So we see this all the time. A child who's 6 years old who comes in to see you and who has wheezing on exam, an expiratory high-pitched noise. This child may be in moderate respiratory distress. He might have a runny nose or congestion or a cough. So what is your medical diagnosis? How do you make that medical diagnosis? Let's drill down on asthma. So before we even get started, though, I want to talk a little bit about the difference between stridor and wheezing. There's a simple trick to be able to help you make a differential diagnosis in a patient who has wheezing versus a patient who has stridor, and I want to make that very clear. Here is a child with lungs, an airway, and two main stem bronchi. If we were to imagine that this child had accidentally swallowed a ball and the ball had landed up in the throat area but had not entered the cavity of the chest, we might imagine that when this child breathed in, there was a negative pressure created below this ball, and that airway space would tighten. As a result, while breathing in, this child would make a noise, a sort of noise, which is from the narrowing of the airway against the ball while breathing in. But while breathing out, you can imagine that this air would blow past the ball, enlarging that area around the ball and allowing for a silent exhalation. Patients with stridor typically have noise on inhalation for this very reason, but not so much in exhalation. This would be a classic noise, for example, in croup, which is a viral inflammation of the upper airway. Now, of course, patients can have inspiratory and expiratory wheezing, but this is classically how we think about stridor. Wheezing, on the other hand, let's now imagine this ball was a little bit smaller and made it all the way down to the right main stem bronchus, or in this case, the left main stem bronchus. It doesn't really matter. The point being, though, that now when this child is breathing in, the airway is expanding, and this is because the entire lung is expanding, so the space in that airway is actually getting bigger, and typically the patient will not have any noise while breathing. However, when breathing out, that area is now collapsed down, and you can see that now the airway will be pressing up against the ball and the child will have an exhalational noise. So wheezing is typically on exhalation more than it is on inhalation. Now, in a patient with asthma, you can absolutely get inhalational and exhalational wheezing as a result of generally very narrowed airways, but we'll typically see the exhalational wheeze first. So if you see a patient with wheeze, what could be causing it? There's a lot more than asthma that causes wheeze, and it's important to know the difference, especially if the patient has never wheezed before. In the infancy period, 0 to 1 years, patients may very likely have bronchiolitis. Bronchiolitis is a viral inflammation of the lung. It does not cause smooth muscle constriction typically, and it's mucus balls, or it's very small amounts of mucus collecting in these airways, which cause a narrowed space and absolutely present with wheezing. If a patient is wheezing, they may very well have bronchiolitis and not asthma, especially if they have upper respiratory infection symptoms like congestion. Bronchopulmonary dysplasia can present with wheeze. A foreign body can absolutely present with wheeze. Usually that's in one location. Aspiration in general, if a child has oromotor dysfunction and has a hard time swallowing, some of that liquid might have gotten down to their lungs. Or anatomic abnormalities of the airway can also cause wheeze. For instance, a CCAM or a congenital cystic adenomatous malformation may be pressing on that airway. In the age 1 to 4, we often see virally induced wheeze, again, bronchiolitis. This may be a case of early asthma. This again might be a foreign body, especially if it's rapidly onset. Mom found the child was normal 1 minute and the next minute was wheezing. And this might be the age at which a child is presenting with the pulmonary symptoms of cystic fibrosis. Over 5 years of age, it's probably asthma. Patients can totally have vocal cord dysfunction, which might cause both stridor and wheeze. Patients may have a hypersensitivity pneumonitis, or patients may get something more complex like allergic bronchopulmonary aspergillosis, which is an allergic hyperresponsiveness to aspergillus in the environment. So if you see a patient with wheezing, what are the key questions to ask? Well, the first is, at what age did wheezing begin? If this is the first wheeze, we're going to manage it a little bit differently than if this child has been wheezing for a long time. Knowing the age of wheeze starting will help you with the differential diagnosis. You should ask whether this wheezing is episodic or persistent. Was it sudden onset, which might be a foreign body, or gradual onset, which might be asthma? Is it associated with triggers? Every time the child is in his dusty grandmother's house, he starts wheezing. That's a strong indicator of asthma. Or has it responded to albuterol in the past? If a child has a history of wheezing which is responsive to albuterol, this is probably asthma. So when you're getting at asthma as a diagnosis, it's very important to get a sense of how severely ill is the patient, because in asthma, the key is control and prevention. So you'll want to ask whether they have many events per week or less than one every 2 weeks. You will want to ask about nighttime awakenings. Frequently, these children will awaken with cough, and that's a good sign of asthma out of control. It's important to ask about whether this asthma interferes with normal activity. Can the child do sports like the other kids? If the child does have asthma, it's incredibly important to know how often they're getting systemic steroids. Systemic steroids, as we'll talk about in a bit, have a lot of side effects, and we want to avoid those. Does the child have a history of previous hospitalizations, or does the patient have previous visits to an intensive care unit? These are all signs of asthma out of control. One key historical fact is, was this child premature? Premature infants have a much higher risk for asthma than non-premature infants, and that can tip you off as to what's going on. So if you are examining a child who you suspect have asthma, it's important, first off, to note their overall appearance and whether they have respiratory distress. In a child with asthma who is in respiratory distress, we are going to first address their respiratory distress and later ask the question about whether maybe this isn't asthma or some other disease. In other words, the typical paradigm you learn of what's the differential diagnosis and now how do we manage the patient is put on hold in asthma because we may not have time to address their differential diagnosis. First, we need to jump to what most concerning. Because asthma represents by far and away the most common cause of wheeze in children, we're going to just address their asthma first if they're in grave respiratory distress and do studies later. We're going to check their respiratory rate and their lung exam. Very important to know, what does it sound? Is there air entry throughout? Is there wheezing throughout? Is it inspiratory and expiratory wheezing? Do they have rhonchi, which might be bronchiolitis? Or do they have crackles, which might be pneumonia? This will help us distinguish these things. It's important to note their heart rate and their cardiac exam, keeping in mind that albuterol, once it's given, is absolutely going to cause tachycardia as a side effect of the drug. But if they're having a high heart rate, it may be because they're afraid or they have air hunger, but it may also be because they're having problems with oxygenation. It's important to examine the liver in an asthmatic, and that might not seem totally obvious right off the bat, but remember, in asthma, the problem is getting the air out. It's obstructive lung disease. These patients are hyperinflated, and it would be very unusual to fail to appreciate a liver. In other words, if you put your hands under the right upper quadrant, you should feel a liver edge in an asthmatic who's having an exacerbation. So expect a little bit of a liver edge in these children. It's helpful to find allergic stigmata, things like hives or eczema, or other findings in a patient with asthma. If you see clubbing or failure to thrive, that is not asthma. Something else is going on, and you need to figure out what is the cause of this pulmonary situation. So those are the key physical exam findings we're going to look for. How do we truly diagnose asthma? On your exam, they may mention spirometry with post-bronchodilator response. Typically, they'll give something like a methylcholine challenge and look to see if they can create bronchoconstriction. A response of around 20% is indicative that this patient is reacting to the methylcholine challenge. The reality is that we don't typically use this test. It's probably not cost effective. The vast majority of children, we simply use a history of responsiveness to albuterol and other stigmata, like eczema, to make the diagnosis of asthma. Rapid viral testing is not helpful. Viruses can be a trigger for asthma. Viruses can happen in patients with bronchiolitis too. And the sad issue is that if you look at healthy children walking down the street, 1 in 4 will test positive for a virus. So viral testing is neither sensitive nor specific. Consider allergy testing or pulmonary function testing really only in children who are over 5 years of age, who you're having a hard time controlling or where you're really not certain of what the diagnosis might be. For a child with a previous diagnosis of asthma who's coming with an asthma exacerbation, we are not going to typically get labs or x-rays. We simply treat the patient. For hospitalized children with no history of wheezing, a chest x-ray is usually done. This is because, again, while we're going to start off presuming this child may have asthma, it's also possible the child has another problem which you haven't figured out yet. An example would be a foreign body, or another condition, maybe a pulmonary lymph node that's compressing the airway. This is the kind of thing where they can look very similar at first, and then over time you notice they really aren't responding to the albuterol like you might expect. A chest x-ray can sometimes be helpful in distinguishing between these problems. So back to asthma. We have a patient who's coming in with an acute exacerbation. They're wheezing, they're right there in your office. What are you going to do? Well, for the acute exacerbation, the mainstay is albuterol. Albuterol is a powerful beta agonist. It's going to cause bronchodilation and allow those airways to really open up. Patients should feel relief relatively quickly. There is an available levoalbuterol, a racemic albuterol. It's more expensive, but not more effective, so most people don't use it. Sometimes we use it because it may have less cardiotoxicity to children with underlying cardiac conditions, but for the vast majority of patients with asthma, it's not necessary. Additionally, during an acute exacerbation, we are going to give systemic steroids. This can be oral, or it can be IV, or it can be intramuscular. Neither route is better than another. They all take about 2 hours to kick in. If you recall, it's a complicated pathway that steroids take to actually reduce inflammation. The steroid has to make it into the nucleus of the cell, which then changes via transcription factors the production of both prostaglandins and leukotrienes. There's this backfilled pathway that if you apply a steroid, it takes about 2 hours before you're going to really notice those steroids kicking in. But they will kick in 2 hours, so get them started as soon as you can. The other important thing in an acute exacerbation, it is a learning moment. So perhaps not while they're acutely ill, but after they've started to get better, it's a good time to counsel about triggers because prevention is what asthma care is all about. So in the acute setting, you may see more than just albuterol used. If the albuterol really isn't turning the child around the corner, they may use continuous albuterol through a nebulized machine. But there are other medications that can help as well. An example would be magnesium. Magnesium is a 2+ ion, just like calcium, and thus is a competitive inhibitor in the sarcoplasmic reticulum of the smooth muscle cell inside the airway. So the magnesium is going to allow that airway to relax. Side effect, though, is that it really relaxes all your smooth muscle, and so you may develop hypotension. Terbutaline is sort of like IV albuterol. It's intravenous. We use it in pregnant women to help with tocolysis. But in children with albuterol, it's given IV and it'll cause more of that smooth muscle dilatation and usually a profound tachycardia. Children on terbutaline are usually watched in the ICU setting. When they're in the ICU setting, you'll note that we like to avoid intubation. If a patient's in respiratory distress from, say, a trauma or a bad pneumonia, we usually will get around to intubating them pretty quickly. In asthma, we're going to generally drag our heels on that. And the reason is, remember, asthma is a problem with getting the air out. If I now intubate the child, I'm going to be pushing more air in, and I'm worried about a pneumothorax, where that lung may actually pop and air may escape into the side of my chest wall, causing a pneumothorax. That's not very good. There are some other agents that can help. Ketamine is a bronchodilator, and some of the inhalational agents like halothane are bronchodilators. There are many different agents we can use in the ICU setting to help dilate those smooth muscles. So in the hospitalized child who's not in the ICU, how are we going to manage these children? Well, generally, we're going to start off with continuous albuterol. In some places, they do that on the wards. In some places, that's in the ICU setting only. And generally, you're going to have a continuous nebulizer of albuterol at very high doses. Then, when the patient is feeling better, they'll generally transition to every 2 hours, or Q2. We'll watch them. We'll use asthma scores to see how they're doing. And once they've been stable for a few treatments, we'll switch them to Q4, or every 4 hours. At that time, they're almost ready to be discharged. And in most settings, we'll wait for 2 Q4-hour treatments. And if they're still looking good, they're okay to go home. We typically discharge them if they do not have an oxygen requirement, if they do not need albuterol more than every 4 hours for at least 2 episodes, and if they don't have respiratory distress. So when we send them home, we want them not to come back again. And the way we're going to prevent them from coming back again is by maintaining a better control of their asthma than they've had before. To decide about control, we first have to decide what type of asthma they have. Let's talk about the different categories of asthma. Intermittent asthma is sometimes called mild intermittent asthma. That's where you have exacerbations now and then, but it's by no means a regular condition. Then you have mild persistent, moderate persistent, and severe persistent. These children have more and more frequent exacerbations, and we'll walk through what that means. But one key thing to remember is asthma in the United States is getting more common and more severe. Deaths in asthma are at an increased rate now than ever before. Children in the intermittent category of asthma are likely to die just like any other category. So categorizing them as intermittent doesn't mean you no longer pay attention to their asthma. It means they need less control or medication. And that's why we're determining their category. How do we determine it? We ask these questions. Are you having nighttime awakenings? How frequently do you use albuterol? How much does your asthma interfere with your normal activity? And how often have you used systemic steroids in this past year? Now you're going to take this information and you're going to then categorize them into one of these categories. These are all outlined in the National Heart, Lung, Blood Institute guidelines, but I'll summarize them here for you. So if you are an intermittent asthmatic, you should have symptoms less than 2 days a week. You should wake up less than 2 nights per month. You should use albuterol less than 2 days per week. You should have no interference with your daily activities, and you should only be on steroids once a year. If you have mild persistent disease, these numbers go up. Where your symptoms are 2 to 6 days a week, your awakenings are 3 to 4 nights a month, and your albuterol use is 2 to 6 days a week, and you have minor interference, and that's a subjective call. Moderate persistent, likewise, it goes up. Now you're having daily symptoms, you're awakening frequently, you're needing albuterol every day, it's very much interfering with your life, and you're using steroids more than 2 times a year. If any of these things are true, you're now a moderate persistent asthmatic. And now we get to severe persistent, and these patients are very sick with daily symptoms all day long. Every night they're waking up. These patients have extreme problems with getting through their day. Now we're going to use this category to decide what kind of inhalational therapy they're going to get as a controller. When we choose a controller, if they are intermittent and between 5 and 11 years old, they're just going to use the albuterol. They don't require a controller. If they're mild persistent, they'll get 2 puffs twice a day of a low-dose steroid. There are some inhaled steroid formulations that are once a day, but most are twice a day. And you have to make sure they're getting it the right amount. Moderate persistent, they're going to give a higher dose steroid, and the example I show here is fluticasone 110 micrograms per puff twice a day. And then if they're severe, you may add multiple medications. This patient is getting both fluticasone and oral montelukast, which is a leukotriene inhibitor. If they're older, we may be a little bit more aggressive once we hit that severe persistent range. Now, we're really talking about using combination therapy of both long-acting beta agonists, or LABAs, with a steroid. Long-acting beta agonists alone without the steroid are contraindicated. There's a black box warning, and it may be associated with death in asthma. The data aren't very good. But the point is, in the United States, because of that black box warning, all LABAs, or long-acting beta agonists, in this case salmeterol, are combined with a steroid, in this case fluticasone. This drug is known as Advair on the market. There's lots of drugs out there. It doesn't matter which kind you choose. It's simply getting the right category and getting the right treatment for the severity of that child's illness. So let's say a patient is on a controller and they've now come in with an asthma exacerbation. How do you figure out what the right thing to do is? They're already on a controller. It may be that their asthma is worse. So the first question you ask is the child taking the controller appropriately? The reality is the vast majority of the time, the answer is going to be no. Either the family is non-compliant and is forgetting doses. The child, often, especially in the early adolescent years, will stop taking their controller because they just don't want to. Another possibility is they've got the technique wrong. Remember, the best technique for one of these inhalers that are meter dose inhalers is to use a spacer, and in little children, a mask and a spacer. Taking it without the spacer, it doesn't work. They're just swallowing the medication. For the discus ones with the powder, sometimes it requires a little bit more coordination, and that child simply isn't old enough to figure it out. So if the child is not taking the controller appropriately, then really the best thing to do is to do more education, to educate this child into how to use the spacer correctly, or to change around what you're using that's more age appropriate. If the child is using it appropriately, this is when you really want to step up your controller medication. And there's a lot of different ways you can do that step-up therapy. So, for example, if a patient has a lot of allergic sequelae, they may benefit a little bit more from getting a leukotriene inhibitor added as opposed to stepping up the strength of their inhaled steroid. Whatever the case may be, understanding control of asthma and prevention of asthma is what's incredibly important to preventing death and preventing long-term sequelae from a patient with asthma. Thanks.